Presentation is placenta alpha macroglobulin 1 and combined traditional diagnostic test, a cost-benefit analysis. Dr. Echeverry.
Oh no!
Thank you very much, Dr. Ye. I'm very excited to be here. It's an honor to be invited to present our paper, Placenta Alpha Microglobulin 1 and Combined Traditional Diagnostic Test, a Cost-Benefit Analysis. So there's nothing to disclose the authors. This paper was not funded, and we don't have any conflict of interest. So 2 years ago, a patient presented to triage. She was 32 weeks pregnant. Her chief complaint was leakage of fluid. I evaluated her using the traditional method, checking for pooling, pH, and Fernin. So on that exam, her Fernin and pooling were negative. pH was positive. So she was admitted with a presumed diagnosis of PPROM. A5 was about 6 centimeters. Intraamniotic injection of indigo-carmine was performed, and it was negative. So some of you sitting here have experienced the same difficulty in making the diagnosis of rupture of membrane when the combined traditional diagnostic test is inconclusive. Bearing in mind that the combined traditional diagnostic test can sometimes be influenced by vaginal contaminants. So on one hand, you have the gold standard intraamniotic injection of indigo-carmine, an invasive procedure with tremendous risk. On the other hand, you have the combined traditional diagnostic test with limitations. So the question I did ask myself is, do we have a test that is better than the combined traditional diagnostic test and at the same time non-invasive? So that question led me to placenta alpha microglobulin 1. Most of you are already familiar with this. This is a biomarker that is highly concentrated in amniotic fluid, low levels in cervical-vaginal discharge if membranes are intact. So Amnisure is a test that was designed to detect the presence of this biomarker. This is a reliable test from the ad, so let's see how reliable this test is. There's numerous publications that have provided enough evidence that placenta alpha microglobulin is highly sensitive and highly specific. Very low false positive rate, very low false negative rate. So the question, if PMG1 is very superior to the combined traditional diagnostic test, how come we don't have this test in all the hospitals in the US? Well, first of all, let's take a look and see how you use this test. It's very quick and easy to use. Per the manufacturer recommendation, no speculum is required. Vaginal swab. You rinse off the specimen in a vial, and then you take a test strip, you dip into the vial, and then within 5 minutes you have your result. So in the previous slide, you've seen the superiority of PMG1 in comparison to the combined traditional diagnostic test. And in this slide, you've seen that it's an easy test to use. It's a point-of-care test. So again, the question is, how come we don't have this test in all the hospitals in the US? That's the main reason. It is an expensive test. PMG1 is $85 per test. The combined traditional diagnostic test is $14. This price includes the cost of the test and the reimbursement fee. So you can see, it is interesting to know that there's numerous publications that have provided enough evidence that PMG1 is very sensitive and highly specific, a very superior test. But up to today, there is no single published economic evidence or any economic analysis comparing both. So, under the guidance of Dr. Nora Dahl, an MFM specialist with tremendous experience in decision analysis, we decided to tackle this problem. We're hoping to be the first to publish this excellent comparison of placenta alpha microglobulin 1 and the combined traditional diagnostic test. So that's our objective, to evaluate if PMG1 will be a cost-beneficial screening strategy in the setting of potential PPROM at 34 weeks to less than 37 weeks gestation. Somebody might ask, why are you interested in 34 weeks and 37 weeks gestation? Well, this is an important gestational age. Remember, ACOG recommends delivery if you're ruptured between this gestational window. expected management can be considered, but the recommendation is for delivery. So if someone shows up 34 weeks and 2 days and you're about to make that decision, which test would you prefer to use? Knowing fully well that you will end up delivering the patient if she is ruptured. So this is our design. Study design is a decision analysis to evaluate all the inputs, the cost of the test, and the cost of preterm delivery. Since it's a cost-benefit analysis, we're talking about the benefit here, which is also going to be in monetary terms. So it's a cost avoidance. This is a cost of preterm delivery. If you avoid preterm delivery, that is your benefit. So technically, the cost of preterm delivery averted. So again, our model is 34 weeks to less than 37 weeks. All computations, analysis, and design were performed using a commercially available software, 3H Pro. To help you appreciate the complexity of this tree, so this is a tree with about 64 nodes, and the branches are about 164 branches. And we have 20 variables. Variables were all extracted from, PubMed, CMS data, and ACOG practice bulletin. You've previously seen the comparison of the sensitivity and the specificity of PMG1 to the combined traditional diagnostic test. So this is just the cost. PMG1 again is $85. The combined traditional diagnostic test is about $14. Now this is the cost of preterm delivery. The annual societal cost of preterm delivery between 34 weeks and 37 weeks. 47,000 is our average, that's what we're using. And you can see the range. When you have 20 variables, and you have assumptions in a cost-benefit analysis model, you risk having so many uncertainties. So to account for the uncertainty in this type of decision analysis, we subjected this model to probabilistic sensitivity analysis using Monte Carlo simulation. In this simulation, what we did was we sent theoretical 1,000 women at this gestational age through the model 1,000 times. That gives you a total of 1 million trials, trying to see if our result and conclusion will change. So let's take a look at the result. So PMG1 is cost beneficial with a cost savings of $12,000 per person tested. It's an annual savings. In comparison to the combined traditional diagnostic test, 61% high, and then a 26% reduction in the first year cost of preterm delivery. So what does this mean? Does it mean we should use PMG1 in every patient that shows up complaining for peak prom within the gestational age of 34 weeks to 37 weeks? Or is there a time that PMG1 is really, or combined traditional diagnostic test is preferred? So what does this really mean? So PMG1 is cost beneficial if your probability of rupture is less than 0.42. So this is the threshold probability. If your probability of rupture is greater than 0.42, then PMG1 is no longer cost beneficial. So you can see that placenta alpha microglobulin can actually generate from $5,000 to $32,000 annual savings. And then a combined traditional diagnostic test is about $5,000 to $9,000. So if you continue to use PMG1 when the probability is greater than 0.42, then you end up having a negative net benefit. So how can this be applied to the clinical setting? So let's say you have a multi, previous history of PPROM. She's been contracting all day, 4 to 5 minutes, and she reports that suddenly she had a big gush of fluid. What is your pretest probability? Bearing in mind that we as clinicians are expected to have clinical pretest probability before we order any test. So in the example that I just gave you, my clinical pretest probability before I even do any test is more than 50%. She has a history of PPROM, she's been contracting 4 to 5 minutes, and she just reported a big gush of fluid. So I think it's greater than 50%. So in that case, I will use the traditional method. How about a priming? She's still the same gestational age, 34 weeks. She reports that she had the urge to go to use the bathroom, and then when she was trying to get off her bed, she has this big gush of fluid. What is my pretest probability? Definitely very, very low. So in that case, I will use the placenta alpha microglobulin 1. So that is how you can actually apply this to clinical setting. And further analysis showed that if the combined traditional diagnostic test is inconclusive, then use PMG1. There's no need to admit them for intraamniotic injection of indigo coming. So in conclusion, our cost-benefit analysis provides the evidence that PMGA1 should be considered in the setting of PPROM, especially in uncertain presentations, or when the presentation is non-obvious. And then when your combined traditional diagnostic test is inconclusive, go ahead and use the placenta alpha microglobulin 1. And in the previous slide, you've also seen that if your pretest probability is very, very high, there is no need to use PMGA1, which means this is not a test-all approach, because if you end up using $85 for every patient that shows up in triage, it becomes economically counterproductive. Thank you.